Hi, this is Brian Wormers recording a lecture for NUR 447. This is Pediatric Nursing, and today we're going to be talking about communication history and physical assessment. So within this, you do know how to do an H&P already. You know how to get a history, you know how to do an assessment, but we're going to talk about what makes pediatric assessment and history a little bit different and go over some of those specifics. So you can look at the objectives here. And we'll go through these here as we go through the slides. So parents, so we talk to the parents a lot, and that's a great thing, and they're usually great historians and they understand what's going on with their child. And so we need to have a good relationship with them, we need to have a good communication with them. And that builds trust, that fosters a relationship between you and the parents, and then of course you and the child as well. And so it's not always accurate. So we do have to watch what the kid says versus what the parents say, or if they're changing their stories. But generally speaking, it'll be consistent. So, anticipatory guidance is great. You're going to hear that throughout this lecture and throughout this course. Think about those things that are coming up that the child's going to go through, and how can we help the parents and the child go through those situations. As we're worried about some of those things, we do use this for decreasing morbidity, mortality, as we know what some of the risk factors are, and we utilize that. Alright, so the big thing is the child's developmental stage is going to be the biggest thing. We don't go by age within pediatrics. They could be 54 years old, but if they act like a 12-year-old, then we treat them like a 12-year-old. And that's important. Also, make sure you watch your nonverbal communications too. Think about how you stand, think about how you're walking. Kids might be a little scared of you, and so they might not just run right up to you, and oftentimes that's a good thing if they have got a little stranger danger depending on their age. So they might need a little time to warm up to you. If they can see that mom and dad or caregiver or whoever it is in the room thinks that you're all right, they'll slowly warm up to you too, generally speaking. Get down to their level. So you can see in this picture that you're squatting, you're kneeling, you're doing stuff to try and get down to their level. You're not hovering over the top of them and scaring them, but really try and get down to their level and do that as much as possible. Watch your clinical instructors, watch the nurses on the peds floor, and see how they communicate with their patients. They'll do this instinctively, and this is just something that you learn to do. Within early childhood, they're going to be afraid of some of the equipment that you use. But helping them see it, touch it, things that they can do. I'm not saying that with like a spinal needle they get to practice with it. However, with a blood pressure cuff, let them see it. Let them see that it's a hose and some tubing, and it's all right. That will go directly down below. If they've got a tubing, they might think that it's a snake or something like that. They respond to things that they've seen before or that they know. And so if they don't know what a blood pressure cuff is or the tubing is, they might make up things for what it is. So be careful with that. Also be very careful with your terms because they tend to be very literal. So stick in the arm, while we might mean it as an IV or an IM injection, they might think that you're putting a piece of wood in their arm. And so they don't always understand the way that you are speaking and the terminology that you use. Just like we'll use colors, like for IVs. So like we'll put a blue one in or a yellow one in. And that tends to be less threatening than, say, we're going to put in a 16 gauge or a 24 gauge. And for those kids that, don't know the gauge system, 24 sounds a lot bigger than a 16, although you know the difference, and you know different than that. So once again, let them play with it as possible. School age, they are, very industrious. They want to help. They want to know answers for everything. They're very inquisitive. So let them ask. Let them, see. Let them help. Let them push the buttons as much as possible. They tend to be concerned with fluid leaking out in genitals. They might not understand the whole clotting cascade that I'm sure that you fully understand. But, if they're bleeding, what's going to have them stop? And they don't understand that. Or, is there something going to ever happen to their private parts? Especially if you're putting tubes in different places. So that can be really scary for them. So adolescents, they go back and forth between concrete and formal operations, and so that can be very difficult. So one time they can act very childlike, and the next time they can be very adult-like, and that will change, and that's normal. But just be aware we meet them where they're at, and realize that this is a normal thing. So in communicating with kids, some of the things we do is verbal and nonverbal. So think about how we're talking. So with little kids, we might do like a sing-songy type of voice, especially with babies. They really like the inflection and trying to go up and down. It draws them to you. Whereas if you do that to an adolescent, they're going to absolutely hate you and think that you're mocking them, and it will not go well. Also think about your nonverbals. Like I said, with the little kids, don't hover over the top of them. It's very similar to, think about your nonverbals throughout the whole room. If you ask somebody, so is there anything else I can get you while you are halfway out the door and you're leaving, generally speaking, they're not going to say, yeah, by the way, come here and fluff my pillow. They're going to be like, oh, well, they're busy, they're on the way out the door, and, they won't bother you for stuff. So, allowing kids to draw can be very helpful. So pictures can tell a lot. So if you think about pictures and, maybe it's a picture of the family and where's mom and dad at? Is it mom, dad, the sibling and the child, and they're all together and they're having a great time? Or is it mom and the two kids and dad's off in the distance somewhere? Is there no mom, or is, I don't know. But you can look at that. Then it's not a given. I mean, you can't say, oh yeah, the mom's abusing their kid based on this picture, but it might be some insight into their world. So drawing, coloring, doing those artistic things like that can be a different type of communication, as well as playing. And so when they play, let them have a doll. How are they treating the doll? What are they worried about? It might come out in their play, and you might be able to ask some good questions with that. So along with that, if we're trying to describe procedures or stuff like that, child's voice or child life will do a great job of using a doll or a teddy bear and kind of explaining things like that. We can use transitional objects. Be very careful that we don't ever lose those. But you can kind of look here and read a little bit more on that if you're interested in it. Taking a history, so you've done adult histories and physicals and stuff like that. So PEDS is going to be very similar, but we do ask some different questions. So the CIM PEDS is a mnemonic that can be helpful. Chief complaint, same as adults, why are you here? Immunizations, we usually ask this of kids, but usually not so much of the adults. In isolation, who have they been around? Have they been at home? Have they been away from school, etc., etc. Allergies should be the same in both. Medications will be the same. Past medical history, hopefully this one's a little bit smaller on your kid, but you never know. Events surrounding the illness or injury. And then diet and diapers can be a little different. So in the adults, of course, have you been eating, have you been drinking, have you been pooping? So talking about the eyes and nose. But we also do check about what do they usually have for formula, or how much and how often. Are they on Isomil, or are they on Infamil, or what kind of formula and what kind of volumes is a big important thing that we need to know. And then symptoms associated to the illness or injury, and that's important in the adult worlds too. Nutritional assessments, we talked about kind of the diet and diapers on the other one. What do they eat? How much do they eat? 24-hour diet recalls are pretty inaccurate because we tend to snack or do other stuff like that. But if they can recall some of the stuff, what kind of quality of food is it? And doing that kind of stuff. They might be a little embarrassed, and they tend to not include all the junk food and the bad food that they've had. So just be leery of that a little bit. BMIs have been growing in pediatrics, so just be careful of that. So much to the point that they've actually got extended growth charts for those above the 95th percentile. So you can click here and look for information on BMI, and in the upcoming slides we got growth charts and different things like that. So goals of pediatric assessment, so we're really trying to minimize the anxiety and the stress related to this. It's not always possible, but we try our best to do non-traumatic care. So foster that nursing relationship. Sometimes we let other people do the interventions to try and foster a relationship with that family and with that kid. Putting a needle in somebody really kind of wrecks your your rapport sometimes. So sometimes we help each other out by not being the quote-unquote bad guy. Prep the child as much as possible and as appropriate. That prep will vary depending on, adolescents will want more. A toddler, give them the basics right before it. And so it really will depend on their ages and their development level. Look at that security between patient and child. Never make the parent be the bad person with this one. And then really try to be accurate with your assessment findings and what you document. If you are taking a blood pressure when they're screaming their head off and their heart rate when you're taking your head off, and you don't document that or show that on the assessment, it really can skew your data. And so as you're looking through, they're like, whoa, why is this kid hypertensive? Well, he was mad at the world, and that definitely plays a factor with this one. Order of exam, you're so used to doing a head-to-toe exam, and you can try to do that, but oftentimes we take what we're given. And so whatever the child leads with is what we'll take. If they're quiet, we try and listen to things as possible. So listen to those heart sounds, lung sounds before the child starts screaming. Try to do invasive stuff last, and that can be temperatures when you're doing the forehead scans, or worse, like the under the armpit thing really bothers infants. Or if you need a rectal one, of course, that's super invasive. Looking in ears is also a very invasive thing. They don't like that because, number one, you're touching them, you're going inside their ear, and when you do it, they can't really see you because it's out of the corner of their eye. And so really try to do those least invasive stuff, activities first, and then move on from there. If you can, make it a game, play as much as you can. If you want to share your stethoscope, have them listen. Sometimes in the school age and preschool age, they love that. But always do all of your stuff as much as possible and then document it well. So if you're looking for examples, infant, preschool, or school age, those are some good examples. Prevention, there's a lot on this slide. And so going over here, so this talks about failure to thrive, especially talking about infants, and there's a great resource here from Children's Hospital of Philadelphia as well as for the NIH, and it talks about that. Periodicity scheduled, so these are the guidelines of when kids should get different exams at what ages. And if you are in private practice or if you're in primary care, this is great. With this, you can see what's required, and if you look here, here's your immunization guidelines. Here's your growth charts. Like I said, obesity is becoming more of an issue, in fact that you can link onto additional or expanded growth charts for those kids that are above the 95th percentile. As you go on, height and weight, what we're concerned about is if they're in the same percentile, that's a great thing, but if they start jumping 2 lines and going from, say, the 25th to the 75th percentile, that's concerning. Why are we jumping so much? Up or down, usually if they cross 2 of the lines, that's more significant. We're really curious about that. And so, otherwise, if they're dropping in their velocity, like I said, increase or decrease suddenly in that growth pattern. Here are the guidelines for when kids should get different assessments and recommendations. This is a great resource. I don't expect you to memorize it, but if you're ever working with kids, Bright Future Guidelines is something that will help your practice. So, head circumference, abdominal circumference, chest circumference, not commonly used, but definitely abdominal head I've seen a lot. Know about your length. In most kids under age of 2 will do a length, and once they start at about age 2, then we'll do height and realize that there's a difference. So length is when they're laying down, height is when they're standing up. Realize that they might not enjoy this, but we do need to get heights and weights, and that's a big part, especially if we're talking about I's and O's, dehydration, fluid overload, stuff like that. Vital signs is a great link from Iowa that gives some parameters. Looking at those kind of things, I know that when you're practicing, it's not a bad idea to have like a little cheat sheet of vitals, and that can help you out. So blood pressures are important. We do that in the hospital all the time. So just make sure you're checking them. So you can kind of look at some of these things. So how are you going to do your vitals? Like I said, least invasive to most invasive. Look at heart rate, respirators before, blood pressure, and then temperatures probably last. General appearance, how do they look? Are they clean? Are they, are they disheveled? Do they have any bugs or dirt or anything like that that you can see on a general appearance? How's their skin? Is it warm, dry, and intact? Do they have lesions, bruises? With some kids, I like seeing bruises. If they're school-age kids or they're, preschool kids, I want to see bruises. I want them to be active and going outside. I want them to have a little bit of a tan, and not just, staying inside watching video games. So realize that there's appropriate things. Some of the bruises, make sure that the bruises are on areas that you'd expect to have bruises. Like middle of the back might be kind of a weird thing, but if they've got a good story, it could be fine. But just look at that and see what that skin looks like. How's their hair and nails, hygiene, all those kind of things. In peds, you might see this. So olden days, they used to call this simian crease. Don't use that. That's kind of derogatory. Kids are not related to apes. So they might call it a single palmar crease. And so if you see this might be indicative like Down syndrome or Fragile X versus this. If you look at your hand and you see this, don't freak out. It can be a normal variant. Chest and thorax, so listen the same way. So you're listening between the ribs, listen to heart and lungs, bilateral, listen to all those, ape to man, or all providers earn their money. So make sure you're hearing that heart, that lungs. If you're really curious, listen on the front, listen on the back, and really, get in there and get a good assessment. Abdomen, very similar. One big thing that you might see is that liver is bigger in kids than what it is in adults. So you might actually palpate it 1 to 2 centimeters below the ribs on that right-hand side in kids. Another big thing is hernias are very common in children. And so some of the stuff is normal. Like if they have an umbilical hernia, oftentimes we won't do anything about that until after the age of 1, until those stomach muscles get bigger and stronger. Now, if you're seeing femoral or inguinal hernias, yeah, that's probably a surgical case, and we got to fix that. Lymph nodes, kids often get sick, and we talked about that in the previous soft chalk, with being exposed to new things in schools or daycares or stuff like that. So they tend to get sick very frequently as their body is trying to make a big immunocompetent list and learn all these different bugs and diseases that it has to fight off. But in the meantime, realize that little kids often will have swollen lymph nodes. That's common. But just note, it's more concerning if it's hard, greater than a centimeter, only on one side, not the other, and doesn't move during assessment. Those are kind of red flags that it might be something more serious. HEENT, so cover, uncover, test, those kind of things. Make it a game. Try and get them to smile, all those kind of things. You're looking at nares, you're looking at eyes. So on this picture, they add this one just because with her eyes, just the way of her face, it might look like her eyes are inturned, but it's just a normal variant based on her race. Ears, I don't expect you to do otoscopic exams. If you do, make sure you put the scope up, and this is what you're looking for. So you're trying to find all these landmarks. It's pearl gray in color. You've got your cone of light coming off along the jawline. But most pediatric nurses do not do this. Most nurses do not do this. However, be aware that ear infections are very common in this age, as well as foreign bodies, and you might see a variety of different things in that ear canal. So oral assessment, so have them open up. So you're looking at the tonsils, you're looking at the tongue, you're looking at the hard palate, looking for any anomalies with that. Let them hold the tongue depressor before doing it. If you can do it without the tongue depressor, that will help your relationship. Most people do not like being gagged, so kids are included with this one. So if you use the tongue depressor, gag them, that relationship's probably going to be harmed. So save it for one of your last activities. You can see how apprehensive this little kiddo is of, the tongue depressor and being there. But just be aware that oftentimes, if you have them roar like a lion or open wide like a crocodile, you can make it a game, and you can do it without the tongue depressor, which will benefit you. GI, we need to make this more standardized. Everybody's afraid to look at private parts, but for an assessment, we really need to do that, because we can see things that might not be normal. So they might have an undescended testicle, or hernias, or might have a hypospadias or hyperspadias, or maybe some labial adhesions. And so if we don't look, we will never see it. Last, neurological, musculological. So realize that they're growing, they're developing, they're getting stronger as they keep going up, and as they're playing games and running and jumping and doing those kind of things. So like I said, make it fun, look at those cranial nerves, make it a game as much as possible. Once again, use developmental milestones as possible, and see if they have any delays or anything like that. Musculoskeletal wise, this is a big thing. Remember in your toddlers that they're going to have that bow-legged. So genuvarum is out, valgum is together, like gum is sticking the knees together, and this is more common in school age. Eventually this will grow out. This is related to the length of the tibia, and they have different tibial growth spurts with this. So they'll start off with this, transition to this, and then they should straighten and become normal. All right, that concludes this lecture on communication, history, physical, and developmental assessment. If you have any questions on this, please feel free to contact me.